So I'd like to thank you very much. I was saying such kind words about you and Dr. Plata for inviting me. You had asked me to talk about neurourology, specifically multiple sclerosis. So thank you for the kind introduction. Here are my disclosures. I wanted to, again, thank Dr. Plata and Julian for the kind invitation. The backdrop here is our new facility at NYU with the Empire State Building on the right-hand side. And we love to sort of show off our facility. But I will say I'm very sad that I'm not with you guys in Bogota now and getting to see your wonderful country. I think that the hospitality and friendship has always been tremendous. And I look forward to a time when it's safe for us to all travel again. I hope that you and all your families are doing well in the pandemic. The outline of the talk today, we'll talk a little bit about incidence of disease. We'll talk about the physiology and neurourologic physiology. We'll mention the goals and evaluation, the treatment modalities we have, other considerations, and then hopefully have time for questions. The disclaimer here is my Spanish is embarrassingly bad. So I'm not going to torture you all and butcher your beautiful language. Hopefully the translator is doing an excellent job keeping up. I know they don't have an easy job if I talk fast. So the incidence of bladder dysfunction in neurologic diseases is quite varied. But one of the reasons I think as a urologist, we take a particular interest in multiple sclerosis and the effect on the urinary system is the very high incidence of dysfunction. And neurourology is quite a challenging topic because of all of the different underlying etiologies and different mechanisms of action for these etiologies. And these are things we need to consider when treating patients to better understand how the disease may change over time and certainly to understand the impact in other aspects of people's care. Multiple sclerosis is a disease that affects the neurons. So the myelin sheath, we believe, is attacked in an autoimmune fashion. And it really does affect all different body systems because the nervous system is the communication from the brain to all these other body parts. And you'll see the urinary bladder is one of these systems, but certainly to remember that it's a disease that affects many aspects is quite important. So in terms of neurourology, the ideal function of the lower urinary tract is to store urine, a reasonable amount, at a pressure that's less than the filtration pressure of the kidney. Which is about 25 to 40 centimeters of water. And thankfully, this is not as much of an issue in MS, but it is something that can occur. And we'll talk a little bit about at-risk patient populations where this becomes an issue. The other function of the lower urinary tract is rapid on-demand emptying when socially appropriate. That means that if people are having incontinence, meaning leaking when they don't want to, then the urinary tract may not be functioning in an ideal way. It's also useful for those of you that are maybe not as much into functional urology is the normal voiding cycle. So we know that the bladder fills, there should be sensations that are normal, and a patient should then have a normal desire to void and initiate the bladder pressure rise, which starts the micturition cycle, and then we have bladder emptying followed by bladder filling. The classification of the lower urinary tract is broken into failures of filling and storage or failures of emptying. And if we think about the function, we can then think about the dysfunction. And we know that there are going to be also anatomic differences in terms of whether the failure of filling or storage is a bladder issue, such as an overactive bladder, or an outlet issue, such as a stress incontinence phenomenon. And then we have failures of emptying, such as a bladder that does not squeeze very well, or a bladder that is potentially blocked by a tonically contracted sphincter muscle. What about bladder innervation? We have both autonomic and sonomic nervous systems. The parasympathetic and sympathetic systems work in concert together to help allow for normal storage and normal emptying. We also know that there is voluntary control of the urinary system, which will sort of turn on and turn off based on what the autonomic nervous system is doing. So for example, while the parasympathetic nervous system is activated, we can then voluntarily relax our external sphincter if neurologically intact. And when our sympathetic nervous system is active, then we can contract the external sphincter when we have a neurologically intact system. So I know that the talk is meant to be about MS, but I thought it was useful to just look at some basic patterns of neurologic injury and the effect that they can have on bladder function. So, for example, lesions above the brainstem often result in detrusor overactivity. External sphincter is rarely dysenergic, if ever. And when we think about MS, we know that MS is a condition that does have brain lesions very commonly. And therefore, when we're thinking about the normal patterns, we would postulate that detrusor overactivity is certainly going to be the most common finding, and we'll see that a little later. If we talk about lesions between the brainstem and the sacral cord, so again, a little bit more classically the description of those with spinal cord injury, but we also do know that MS can have spinal cord lesions. And so certainly when we're starting to see this, then we want to think about these other patterns. So generally the condition will be associated with detrusor overactivity, and plus minus, maybe they have sphincter dysenergia. And again, complete lesions above T6 that can result in bladder neck dysfunction, but that's not something typically seen with the MS population. And then finally, the third pattern is the lesions of the sacral cord and distal. Again, less common in MS, not something we expect to see. More commonly, if we're talking about distal nerve injury from, let's say, a pelvic exenteration, but again, often detrusor acontractility is going to be the pattern. It's important when we look at pathophysiology or physiology of the nervous system to consider some of the neurotransmitters. And this still remains one of my favorite photos that makes it into many of my talks, looking at the nerve transmitter, the nerves and the receptors where they lie, which not only helps us understand the dysfunction, but also helps us think about treatments with muscarinic or beta adrenergic receptors. There's also quite a bit in paracrine function, which goes beyond the scope of the talk today, but just to remember that these are, in fact, little molecules that do have signaling pathways in our nervous system. So what are the goals of therapy for the neurogenic patient? Safety is really paramount. This is the most important thing, and our goal here is to protect renal function, preserve sort of the upper tracts, prevent infections, and also things like skin breakdown. Certainly, this becomes more of an issue in the more advanced patient population with MS, and we'll talk a little bit about why this is more of an issue in males and females. But again, we can all agree that safety is the most important. Then we need to treat our patients and treat the patient's symptoms. So we want to treat their bother and we want to treat quality of life. One of the unique things about MS is there often are caregivers that are involved. So we're balancing sort of the wishes of the patient with the caregiver. And sometimes that can be ethically a bit challenging as a physician, but nevertheless, often those goals do align. And thankfully, these are the two sort of easy tasks that we have in terms of treating patients. On the bottom, you'll see an ultrasound showing hydronephrosis of a kidney. That would be something we would not want to see. And then the idea of showing quality of life measures and some of the measures that are used to really assess how these conditions of incontinence, for example, are affecting our patients. This MS population is, I think, very rewarding, but challenging at the same time. And what it really does require is a multidisciplinary approach. We can see that there are multiple aspects here: the psychological, lifestyle, comorbid health conditions, mobility, cognition, which are things that as urologists, urogynecologists, we may not be as equipped of dealing with. And really where we focus in is the sphincter, the detrusor, and then the infections, if we consider that as a separate category. So I do challenge you to look at things differently. When we deal with patients with MS, we have to consider how we are set up. Are we accessible for patients with wheelchairs? Are we accessible to get patients to transfer over to a bed so that we can properly examine them? All too often, because of mobility issues, we're forced to do an examination with a patient sitting in a wheelchair, and it's very difficult to assess, for example, sphincter function, urethral patency, pelvic floor muscles, when these patients are, in fact, not actually able to be in lithotomy. We also have to consider other conditions such as depression, memory issues, body image issues, mobility, dexterity when you are treating these patients. And a lot of these patients, because of, again, their inability to work, perhaps issues with insurance, perhaps issues with cognition, are not able to get some of the basic primary care that our other patients have. So I guess we could say, well, maybe the dysfunction of the bladder is not a priority, and that's why not all of these patients come forward to see us. But if we look at this study, a couple of years old now, but it looks at those that are having the symptoms that are having moderate or high impact. And what we realize is bladder problems really are right up there, almost as high as loss of mobility and dizziness or balance issues. So I think that these conditions do bother patients tremendously, but other barriers must exist. And this was a paper from a few years ago where we actually asked patients with MS at our MS center here at NYU why they had not ever seen a doctor or what had sort of prevented them seeing a doctor. And you'll see, again, sometimes the physician never asked, so meaning the neurologist or the primary care never said, would you like to see a bladder specialist? Or the doctor never gave them a referral. Some patients did feel overwhelmed with other conditions. And then there were, unfortunately, other patients that continued to feel embarrassed about asking or felt like there were no treatment options available. So of the patients, based on this actionable screening tool that was validated in the MS population, of those patients identified as being appropriate for referral to urology, only about 30% of patients saw a urologist. And then if we looked at the patient's wishes, that number did increase, but is still astoundingly low, with only about 44% of patients who wanted to see a urologist actually seeing a urologist, indicating that other barriers do exist. So I would argue that that study, those are my patients, but I think if you look in the literature, you'll see that this is a theme that has been going on for a long time in MS. MS patients with greater than one bothersome symptom, only 41% were being treated with non-antibiotic medications. Again, patients that also included 60% of patients with at least one urinary tract infection in the last 6 months. Patients that had had greater than 3 UTIs, a group where we would say they're at risk for some of those safety issues, only 12% had ever seen a urologist. 75% had never had a PVR checked. And again, a lot of these patients really had more than just minimal symptoms. So you can understand that there really is a gap. So what do we have for guidelines? I think that when we're considering the treatment of patients, certainly we want to have some guidance. And what does the AUA say? This is from a guideline on urodynamics. And I think the concept of performing a post-void residual, again, we can all agree is probably quite useful in the initial evaluation of a patient with a relevant neurologic condition. And I would actually say that I think that this is a relatively straightforward measure, and there's pretty good evidence to suggest that. Now, what about urodynamics or complex CMG? Here, the jury's still out. And the answer is there are certain relevant conditions where this is appropriate, and then there are going to be other conditions where it may be more than is necessary. So we know that we should perform pressure flow if they're a relevant condition, which we'll talk about in the next slide, or if they have symptoms or the patient has an elevated post-void residual or significant urinary symptoms. And so that's where the post-void residual becomes quite important, and we use it really a lot in the patients with MS. So what are relevant neurologic conditions, and what's the implication for MS, which I was asked to speak about? We know that the risk of developing renal impairment in a spinal cord injury patient is quite real, a lot less common from someone that has a brain tumor or CVA. But where does MS fall? So it turns out that men with MS are considered a relevant neurogenic condition versus female with MS, in most cases, are really considered not someone that is at risk of developing renal impairment. And certainly, again, there are going to be exceptions to this rule, and that's where the clinical judgment does become important. I'd be remiss if I did not mention fluoroscopy in the evaluation of these patients. And certainly, Vic Nitti, my mentor, taught me a lot about fluoroscopy. And it is quite important to realize that this is the patient population where fluoroscopy does have a major role. EMG can be combined in relevant conditions. Again, we've written and sort of talked a lot about the idea that sometimes fluoroscopy, in my mind, is a little easier to interpret, but nevertheless, the urodynamic guidelines do suggest fluoroscopy and EMG for those with the elevated post-void residual or relevant neurologic conditions, and those without urinary symptoms, elevated PVR, or relevant conditions don't necessarily need a urodynamic study. So this is a good example, a 21-year-old with spinal cord injury, catheterizing, leaking between caths, versus a 47-year-old female with MS diagnosed 4 years prior with no difficulty emptying, no recurrent infections, no previous surgeries. And you could understand why the first patient does get a video urodynamic as part of the initial evaluation. And the second patient, I'm going to follow a post-void residual, follow symptoms, and I'm okay starting them in empiric therapy. This was another work that I was involved with SUFU, looking at neurogenic patients. And because there are going to be MS patients that do get urodynamics, I thought it was worthwhile mentioning that the recommendation, though the level of evidence is not great, does suggest that we use antibiotic prophylaxis when performing urodynamics in this patient population, those with neurologic lower urinary tract dysfunction. Antibiotic prophylaxis is recommended for urodynamics patients with indwelling catheters, such as a suprapubic tube, condom catheter, or a urethral catheter, which is another potential scenario you may run into in your practice. Relevant conditions. Again, this is maybe a little bit more fitting for the spinal cord population, but certainly it's important to remember that severity of symptoms and physical exam do not always correlate well with prognosis and danger of the upper tracts or urodynamic findings. And we also do know that in a lot of neurogenic patients, the management is often dictated by the urodynamics. So that's why we do still perform urodynamics in this patient population. I just threw in an example tracing. I thought this was an interesting urodynamic of a patient I just saw back the other day recently, and made me think of him. This was a gentleman who had significant wetting issues as well as urinary tract infections. And this was what the urodynamic looked like. So significant overactivity, very messy study, as you can see. It does look like maybe there's some increased EMG. And this fluoroscopic shot, I was fairly convinced that this gentleman had DESD. But again, when we sort of looked at him, he was ambulating. His recent MRIs of his spine didn't have any spinal cord lesions. And I said, look, if he doesn't have a spinal cord lesion, I don't know that this is DESD. I'm not quite sure why we're getting this high pressure, low flow with leakage. And lo and behold, it turned out that we placed him on a medication for overactive bladder. This overactivity went away, and this voluntary guarding that we're seeing that was quite severe because he didn't want to leak actually totally abated. And when it's all said and done, this is just an example of significant neurogenic overactivity in an ambulating young man with MS. And when we treated him, the follow-up urodynamic really showed almost a normal-looking fluoroscopic image, which I think is actually one of the more interesting cases in the MS patient that I've seen. But what are the typical patterns? This was a great study looking at sort of all of the different potential abnormalities. And as we mentioned, based on the pattern of injury of the neurologic disease, most of the patients that had an abnormality had NDO, or neurogenic detrusor overactivity. DESD, it can happen. There are spinal cord lesions that happen in stranger areas where plaques can form. But again, it's not the usual. We also do sometimes see those with detrusor underactivity. And there are some patients that have no abnormalities. The incidence of these does vary based on the patient population, and certainly depending on where you're seeing patients in your country or your area. There may be patients that are much more ambulatory and lower impact in terms of disease state, versus there may be some that are really significantly disabled and having more issues with bladder emptying. The number of urodynamic studies has decreased. And I think that the statements that I showed before and the idea of really classifying patients does show that there's a divide. And there are some patients that are at high risk. But over the last 10, 20, 30 years, we've started to learn that we don't necessarily need to do urodynamics on everybody, but certainly it does increase in frequency with increasing disability. A systematic review in the Canadian Urologic Society journal ended up showing that the optimal surveillance is lacking. So there's evidence that the urodynamics is likely to modify patient treatment and often demonstrates findings that modify treatment in the absence of symptoms or imaging, which I think is their way of making a statement to say, yes, this is still a study that is useful in this patient population, though we really are looking, it seems like, in lots of other indications in female pelvic medicine as to why not to do urodynamics. I would still argue that they are quite useful, and certainly this is a patient population where they are. What about the prevalence of DESD and low compliance? Well, again, this is where the concept comes from. Spinal cord injury, there is a risk of having impaired compliance, but MS patients have a low incidence. This is the EDSS score, and what they sort of looked at was, depending on the EDSS score, how able are we to predict impaired compliance? And you can see if we use a cutoff of an EDSS greater than 5, it had an 86% sensitivity and a 50% specificity for predicting impaired compliance. So the EDSS quite useful as sort of a cut point. I think it is important to realize, as you risk stratify patient, those that are needing assistance for ambulation really do often have more of a at-risk type situation than those that are ambulating. So what about the treatments? I had mentioned the classification of lower urinary tract dysfunction, but that classification can also help guide the treatments. So how do we actually treat lower urinary tract symptoms in this population? It's quite important to consider behavioral modifications and conservative management. These are things that often are very low cost, very low side effect, and can be quite effective. Something as simple as explaining to a patient how much or how little they should drink or what fluids to avoid can have a tremendous impact. We also need to consider other issues such as their living situation, mobility, dexterity, and don't forget to consider counseling them on bowel regimen, something that they often lack, as well as weight and weight reduction if they're not able to be physically fit or physically active. What are the medications or ways that we can treat storage problems? So we have anticholinergics. Certainly there is some data here to suggest that these can be used in patients with MS, but there is sort of a growing concern about side effects, both cognitive impairment, confusion, but there's also issues with constipation, dry mouth, and tolerance, though this medication probably is the best studied in the MS population. We have beta-3 agonists. We have mirabegron, again, may have a small blood pressure effect, but it theoretically should lack confusion and constipating side effects. We just don't have robust clinical data in MS patients. And then in the United States, recently approved vibegron, a new beta-3 agonist, very selective, also known as Gemtesa, which perhaps the advantage here in the MS population is very few drug-drug interactions based on where it is metabolized. And it's also a crushable pill, which does become important in some of our more advanced patients. We have third-line therapies, which we'll talk about, and then surgical reconstructions as well sometimes need to be used. The cognitive impact on anticholinergic medications, is something that's gotten a lot of press in the States recently. And AUGS, the Gynecologic Society, came out and really said, you have to choose these medications wisely. But this is something that our MS colleagues have been aware of for quite some time. And this was a nice study looking at patients that were using anticholinergic drugs versus not anticholinergic drugs, and the impact on how patients scored on different modalities of recall testing and et cetera. And I think the answer here is there may be a signal, but it really does sort of suggest that maybe MS patients are a little bit more at high risk of developing cognitive impairment at baseline, and they may be more susceptible to the cholinergic drug effect, which is why now we are, again, using these medications much more cautiously. So there's not a lot of data using beta-3 agonists in patients with MS, but one of the things before we really got too concerned about cognitive effects that we sort of would always hear from our patients was the idea of constipation. And so what we did was we prospectively looked at patients and randomized them to mirabegron or solifenacin 10 without any dose titration. And we wanted to see if the drugs worked equally well and what the impact on constipation was. And you could see the bars, the blue bars being mirabegron and the orange bars being solifenacin. The drugs worked quite well in both patient populations. And you can see that the worsening constipation was actually much less in the mirabegron group, which is sort of what you'd expect to see. I think now I have a little bit more confidence to say, even though the drug is not studied as widely in the MS population, I think it probably works as well, potentially with fewer side effects. Obviously, cost and access to these medications may still be a barrier, but I think we need to push the people that make these decisions in our governments and our health systems and our insurance companies to really advocate for a medication that may work better or may work the same, but with fewer side effects. Onabotulinum toxin approved for the treatment of NDO if patients have inadequately been treated with oral medications. And the pivotal data for this approval at the 200-unit dose in the States was based on a large population of MS patients. We don't really have as much data to talk about compliance issues or that poorly compliant issues. And we also need to consider the impact on bladder emptying. This was a nice systematic review that one of our fellows, Benoit Perronnet, had put together when he was with us a few years ago, looking at the treatment use of Botox in neurourology. And you can see many studies here, good high quality studies looking at MS patients, comparing 200 and 300 unit doses to placebo, and yes, effective at reducing leakage across the board. But one of the things that came up was our patients that were non-catheterizing MS patients did not want to catheterize. So again, we sort of now decided, well, what would happen if we used a lower dose of Botox in these patients? And instead of using a 200-unit dose, if we used a 100-unit dose compared to placebo. And yes, it does turn out that this medication still does outperform placebo in the non-catheterizing MS population. And the CIC rates were cut in about half, from about 30% in the 200-unit studies that had historically been done, now down to about 15% in this study. Granted, it's a different patient population, but I do think that clinically we're looking for any edge that we can get to get a patient to utilize this therapy and perhaps avoid the need for CIC and then the introduction of issues with asymptomatic bacteria, etc. So what about sacral neuromodulation? Sacral neuromodulation is a great therapy, but really the issue here, again, is a little bit of lack of data. There's no specific FDA clearance in the States for neurogenic patients, but the sort of word on the street is one of the new companies to market is going to be perhaps submitting some of the historic data that exists out there to say, hey, we think that this can actually work. I think that in the severely devastated MS patient, it's probably less likely to work just based on mechanism or proposed mechanism of action. But certainly what I sliced out of this talk was currently precluded from MRI below the neck. In the States, the InterStim 2 and now the Axonics device that's available, they are all MRI compatible. If a patient has an old device, they still are only allowed to have MRIs above the neck. But I think that this is really going to open up the gateway for us to sort of be a lot more liberal at using this technology, though we need to be sort of cautious in using it. But a lot of the appeals come because the product is also approved for bowel issues or bowel incontinence, fecal incontinence, as well as for incomplete bladder emptying. I don't think that this is a therapy that's going to fix all incomplete bladder emptying in MS, but certainly for that ambulating MS patient that's concerned about intermittent catheterization, for example, with something like Botox, they may do very well with neuromodulation with either of these devices. And the nice thing is it can be tested. What about PTNS? PTNS, minimally invasive. It does take some time, but again, a limited studies exist. I sort of put out this data because I think it's the most promising in neurologic patients, where patients with Parkinson's, so a little bit of a different patient population, but nevertheless, in some ways, really maybe a more severe overactivity group. We do see a reduction in voids. We do see a reduction in urgency continence as well as nocturia episodes. Another topic that one of the neurologists here at NYU really was quite good at sort of addressing, who's since passed on, but Dr. Herbert always talked about travel incontinence and sort of how do you get patients to be comfortable going to their child's graduation or coming in to see the doctor. And so he talked to them a lot about fluid manipulation, compression stockings, sometimes using short-acting anticholinergics, but also he used desmopressin a lot. We sort of look at it a little bit more for the nocturia patient population, and we know that it can be effective. We know that it's going to work sort of to reduce the volume of urine that is created, and there are some risks of hyponatremia. A few new medications may be available in your locales. But in thinking about nocturia in MS patients, we really need to realize that they're quite prevalent. It's a quite prevalent condition. Some upwards of about 50% of patients. The underlying pathophysiology is complex, and it may actually be somewhat different than the non-neurogenic population because of disorders of blood pressure regulation in some of these patients with spinal cord lesions. We also need to remember that fatigue is a symptom of MS, and sleep disorders also can occur in neurologic conditions such as MS. So you have this sort of circle of different modalities or different etiologies that are ongoing. Nocturia patients, again, in terms of why nocturia may be a little bit different in MS. Certainly, there are some things like obstructive sleep apnea that can occur in a non-MS population, but we have daytime lower limb venous pooling due to neurologic impairment. And then also the theory that there's a lack of diurnal variation of ADH production driven by spinal cord lesions. And then we also have the same autonomic cardiovascular dysfunction and how that actually factors in. So I think very interesting to think about MS patients in this way. This is really how we treat the MS patient population. Again, a nice review that we had put together with the citation here on the last page in Reviews in Urology. But here we sort of can talk about, is this an issue where we need to work on bladder capacity? Is it a actual nocturnal polyuria issue or a global polyuria issue? And sort of treating this in the context of MS. So things like the voiding dysfunction, if the patient's bladder is not emptying well, then perhaps something like intermittent catheterization can help. What about bladder emptying? So we, as urologists and urogynecologists, we know about sort of emptying CIC, suprapubic tube, and indwelling urethral catheter. Obviously want to try to avoid the urethral catheter. And this is showing a woman that really has a deficient dorsal urethra because of an indwelling catheter. The UO was quite close, and that's why there's a stent in there. But she ultimately, subsequently needed a bladder neck closure with a suprapubic tube placement, which is much more complicated. And I don't like doing that as much as just sort of going to the suprapubic tube right off the bat if that's what she decides. We have catheterizable channels as an option. Need to consider sort of what's going to happen as the disease progresses or may progress. Sphincterotomy and then diversions, continent and incontinent, as well as other surgeries that may affect men, such as an enlarged prostate. We can't forget to treat the patients as we would any patient. In the last couple of minutes, I wanted to talk about another problem that's quite prevalent, which is sexual problems in persons with MS. And you can see that in women and in men, the incidence of this is much, much higher than the general population. Examples of the reasons: mobility issues, medications have effect, body image, fatigue, as we talked about before. If you're too tired to sort of do the things that you need to do, then you're not going to be able to do the things you like to do. Nerve sensitivity can also be a problem. And don't forget that if a patient's having incontinence, they may not really want to be intimate with a partner. Other considerations in addition to the sexual function here and some of the adaptive technologies that can be used so that patients can have a pleasurable experience. Urinary tract infections, we don't really have enough time to go into this, but this is incredibly costly and morbid. And I think a lot of this comes down to education and sort of appropriate conservative type measures. We need to educate primary care and neurology that not every sort of asymptomatic bacteria patient that's catheterizing needs to be treated with antibiotics. And it takes a lot of time and effort to convince patients that, again, a little bit of fatigue is not necessarily a urinary tract infection or some pseudo-exacerbation from MS. Bladder cancer is also something we need to consider, especially for those with indwelling catheters or suprapubic tubes. Gross hematuria should be worked up. If a patient has a catheter in place, has gross hematuria, have a low threshold to work up that patient. And additionally, if they have a suprapubic tube or an indwelling catheter, they are at a higher risk. Guidelines do have some limitations. A lot of the guidelines, the evidence is poor. So I'd encourage you all, if you have these patient populations, to try to publish and write about them or collaborate so that we have better evidence. And there are also certain domains that we don't necessarily have very well explored either. So with that, I wanted to leave a few minutes for questions, and I wanted to thank a lot of the people that I work with day in and day out. I'm very fortunate to live in two worlds, the Department of OBGYN on the top and the Department of Urology on the bottom there. which really allows me to do what I want to do. And I sort of get pushed by these people every day and want to thank them for the support. But most importantly, my sort of close colleagues in our section of FPMRS. We have Dr. Lauren Stewart, Narit Rosenblum, myself, and recent addition, Dr. Christina Escobar, our fellows and some of our staff. These were all taken, the group shots before the pandemic. Otherwise, we'd all be masked at this point. But it's nice to remember the way things were. And with that, I will end the presentation. I'll leave this up for a moment before I stop sharing my slides. But please do reach out, call if you have questions, and my Twitter tag on the bottom there.